Anthony DeMaria returns, this time with Dr. Jacob Udell, Associate Professor of Medicine at the University of Toronto in Canada, to discuss long-term cardiovascular risk in women prescribed fertility therapy.
So, Dr. Udell, tell us, how did you get interested in this topic?
Well, as I was completing my fellowship in internal medicine and cardiology, I had an interest in pregnancy and heart disease. When I was rounding on the wards at the University of Toronto and then subsequently at the Brigham and Women's Hospital, we were seeing a lot of women who were presenting with potential complications as a result of fertility therapy. At that time, I didn't even realize there could be potential medical complications, but it turns out that overstimulation of the ovaries with these fertility medicines can result in a third spacing capillary leakage syndrome called ovarian hyperstimulation syndrome, which in its extreme forms can result in hemoconcentration and then ischemic events and other thrombotic events. And then emerging literature has been suggesting that there may be associations because of intermediary developments of gestational diabetes and hypertension and thromboembolic disease, where we wondered whether there's any long-term consequences to any of these effects and whether we're just scratching the surface with these very critical events. And so Dr. Rettelmeyer and myself delved into this with a population-based study in Ontario, looking at whether there's cardiovascular events long-term in these women who are using fertility therapy.
How much fertility therapy is being used these days?
It is certainly exponentially going up. What we can capture and what is going on in the private market are probably different things. Certain populations and certain geographic regions allow for us to use administrative health databases such as the ones in Ontario to look at that use. And we estimate it to be approximately 1% of the general public or women of childbearing age that are using fertility therapy. However, there's likely a lot of private use going on that we can't capture in these public health administrative databases, and that has been reported in other regions, especially in the United States.
Well, I'm surprised nobody's looked at this before. Have there been any earlier data, any suggestion of adverse cardiovascular risk?
Certainly. During the peripartum period, there have been these odd reports of upper extremity DVTs, or as I mentioned, ischemic outcomes that could happen. Stroke risk is going up in women who are of gestational age who are using fertility therapy. Of course, one has to consider, though, the confounding with advanced maternal age in the use of these medicines. That could be one of the drivers to why there's this signal perhaps for increased risk. So a lot of these studies, unfortunately, are either small case control studies or small cohort studies that just didn't have the power to look at this and that we were able to leverage using these population administrative health databases that we have at our disposal in Canada.
So, of course, one of the major issues in a registry study such as your own, even though you have a very large patient population, is that there may well be differences between the specific groups you're comparing. So, were there differences in the patients who received fertility therapy as compared to those who didn't?
Yes, I think that's a valid question and argument that could be made of this type of analysis. Although, of course, there are many strengths of approaching it this way, then we couldn't figure another way that would be as strong. That said, in fact, if anything, the patients in the fertility arm were probably at baseline at increased risk, one would hypothesize, for cardiovascular outcomes. For instance, women who used fertility therapy were on average 5 years older than women who had a first pregnancy without fertility therapy, as one might intuitively expect, as well as they saw their physician more often, in fact, quite more frequently. When you look at the prior 6 months of MD visits, women who use fertility on average, again, were seeing their physician about 50 times in the last 6 months. You might imagine this is quite an important time in their lives compared to women who, again, childbearing age that were compared to those patients only saw their physicians 12 times in the past 6 months, as you would imagine if you were pregnant going in for monthly or semi-annual visits. And similarly, as you looked at other major comorbidities, patients who used fertility had a higher incidence of past history of cancer and other risk factors that might make fertility more difficult. So going into the study, we did hypothesize that patients who use fertility therapy would be at increased risk, and perhaps it was confounded by the increased risk factors at baseline.
So how many patients did you follow and for how long, and what did you find?
So of those who use fertility therapy, we started looking back at the beginning of basically administrative cohort data, which is in the mid-90s until mid-2010. And we found about 7,069 to be exact, women who had used fertility therapy for an index pregnancy. We considered the first pregnancy that we could capture in the database to be the one that we would look at, and not repeated pregnancies because of the potential for clustering. Compared to the general population of women who of childbearing age was about 1.2 million women. So as you mentioned, quite a powerful control group to look at. And we followed them up for a median of just under 10 years and found that in those women who used fertility therapy, there was an increased risk in the peripartum period for gestational hypertension, diabetes, preeclampsia, and other placental complications, all of which have been linked to independently long-term risk of cardiovascular outcomes. And when we looked at the unadjusted analyses, we did find that there was no difference between the two groups with regards to our primary outcome, which was death or a major cardiovascular endpoint, ischemic endpoints, heart failure, venous thromboembolic disease, and stroke. But after multivariable adjustment, paradoxically, actually, those women who used fertility therapy had an independent decreased risk for those long-term outcomes. In fact, the hazard ratio was approximately half that of the control group.
And why should that be?
Well, we were fascinated by that question too and planned prospectively to look at other outcomes aside from cardiovascular outcomes to see if we could explore why that might be. We first wanted to look at things that may be associated with using high doses of fertility therapy, such as potentially hormone-related malignancies, such as breast ovarian cancer, but there was no signal there. We also looked at what we call tracer outcomes that we thought would have no association, such as pneumonia, kidney stones, and we found no association there. And then we looked at some social health or psychosocial health outcomes such as motor vehicle collisions, depression, or self-harm, and found quite a substantial associated benefit, protective benefit, in those who use fertility therapy. And we were making the argument that likely one of the major confounding here is a selection bias of these women who decide to invest all their time and effort to having a child, that these likely are leading a healthier lifestyle compared to women who are having spontaneous pregnancies and children.
Not knowing the Canadian system very, very well, I would imagine that they're probably socioeconomically in a better position.
That's a good point. We did look at socioeconomic status. We stratified SES status by quintile, and across the different socioeconomic groups from the lowest to the highest, we found no statistical significant interaction with socioeconomic status in the outcome. We too hypothesized that perhaps there was a driver there with regards to these women usually being more affluent or having, especially if it was private, the ability to afford to pay for fertility therapy, which in Ontario, in contrast to where I trained in Boston and Massachusetts, in Ontario, fertility therapy has been actually delisted as a universally funded therapy, except in extreme circumstances, whereas for instance, in certain states, in the state of Massachusetts, it is actually covered under most people's health plans.
Well, very interesting. I guess the major implication of your findings would be in counseling. I guess this would be very reassuring to women who are about to undergo fertility therapy. It would be very reassuring to have the knowledge that this wouldn't put them at increased risk for cardiovascular events over the long term, even though they might have during their therapy more diabetes, perhaps more gestational hypertension.
Correct. We kind of are taking the glass half full, glass half empty approach. We certainly do want to reassure women who are undergoing these treatments that there seems to be no signal for harm. But at the same time, given these potential risks with regards to gestational metabolic complications that could lead to long-term risk, it's an opportunity, just like many other potential quote-unquote stress tests in youth that eventually end up potentially having some outcomes later on. It's a potential opportunity if there are risk factors that are identified during the pregnancy period to address them early on, because they are technically still in a group that is more advanced in age and other risk factors. But it is nice to be able to reassure folks that we aren't giving a therapy that is associated with cardiovascular outcomes.
Sure, and presumably even in those patients not receiving fertility therapy, you're going to be very closely attuned to cardiovascular risk during the pregnancy.
So all the more so in these women who are making this time and effort and investment into their families and their future.
Well, very interesting data. Congratulations. It's a real-world sample, very large. It has all of the potential limitations of a retrospective analysis, but nevertheless, really very well done, and I think very useful to the increasing number of women who are seeking fertility therapy. Thanks very much for sharing this with us.
Thank you, Dr. DeMaria.